everybody. I might say a small select group of us coming to the Pain Learning series today, and Claire is going to talk about fibromyalgia. It's a really common problem, and hopefully there'll be a fair number of people watching the recording. So on you go, Claire. Thanks very much. I don't know if you want to share some slides as well.
Yeah, I'm just doing it just now. Okay, so I'm just sorting out my screen this end. Hang on. Oh, that's better. Okay, so I was asked to give this presentation on fibromyalgia, and it's probably I've got slightly too many slides for the time because I gave the same talk to the rheumatologist last week. So because we're such a small group, please just chip in and ask questions as we go, and you don't need to wait till the end. And if I say anything that you want to discuss, then just fire in at any point, anybody. So yeah, I thought I've titled it "Exploring the Misdiagnosis, Management, and Best Practice of Fibromyalgia." So it's quite a big topic, and I definitely won't get through it all. But I thought that a good place to start, I think, with fibromyalgia is to address some of the controversies and myths that surround the diagnostic label. And certainly, kind of throughout my 20 years of practice, I've been very much aware of the kind of debate and widespread differing opinion that exists both sort of within medical practice research and just in kind of society at whole. And although I'm definitely a massive fan of debate, and I think that kind of the conversations that we have clinically are always very valuable. I think that some of the debate and controversy surrounding fibromyalgia um, are really quite unhelpful, and they certainly create uncertainty through throughout kind of clinical practice, and most importantly in the patients that we support. So it's a complicated diagnosis in that it requires a whole person assessment, and it can be challenging to bring all the varying aspects of the presentation together. So there often is that sort of delay in diagnosis, and the lack of a kind of clear definitive test as well always creates challenge. Um, the in when I was doing a sort of retrawl through of the literature for this, there were varying things that you came across, like statements saying that it was a bitterly controversial condition and describing the wars over legitimacy that have occurred between the various fractions that have an interest in fibromyalgia. With the kind of that have created this sort of sometimes this mind-body dualism where you've got kind of the psychological aspects on one side and you've got the physical aspects on another side, and the kind of lack of team working sometimes that have created problems. Um, the there is also kind of controversy regarding the diagnosis label itself, the label of fibromyalgia, with a kind of belief that it can promote illness behavior, and kind of medicalization of the presenting group. And I think that those kind of things are the things that have caused problems with management of this condition. And have created stigmas. And one of the real sort of exciting challenges, I suppose, at the moment is just the enormity of research in this area that definitely is creating quite a kind of fluctuating landscape, because our understanding of the condition is always changing. So although that's kind of exciting, it's another thing that's adding to the challenge of the condition. So I thought I would address some myths more specifically so that we can kind of just discuss and perhaps debate around about them. So it's sometimes thought of as a diagnosis of exclusion or a kind of end of the road diagnosis. But fibromyalgia is a condition that coexists with other conditions, and that you do the diagnostic workup is complicated, but the investigations is more to kind of rule out other conditions that can have an enormous bearing on the presentation that you're faced with, such as sleep apnea, depression, that need support, kind of alongside the other diagnosis, and also excluding other drugs that can present with widespread pain as part of their side effects profile. And it's definitely the new guidelines that I'll go into in a bit more detail they're supporting people to make the diagnosis at a much earlier stage, and alongside other working diagnosis and alongside other investigation. The other myth is, I've kind of labeled it under somaticization. So, the manifestation of physical symptoms by psychological distress. And although depression, anxiety, history of trauma can be present in some, it is not present in all, and mental distress is not causative, but it does increase the risk, and if it's present, increases the severity of the presentation of fibromyalgia. And recognition of kind of concurrent psychological distress and diagnosis is imperative to manage fibromyalgia well, and support it. And in pain science at the moment, there is, alongside the kind of very exciting expanse of our knowledge in the area, there is, like with all swings in medicine, I think there's a little bit of a lean to sometimes pain being classed as all in the head or all centrally driven. And although there is a component of central sensitization present in fibromyalgia, it is a whole person, peripheral and central condition, and all those factors are important. The other myth is that it's a condition that dominates, that has dominant presentation in middle-aged women, and although there is a 2-to-1 female to male prevalence, traditionally it was thought that it was an 8-to-1 female to male presentation, and that was based on the old classifications where actual palpation was used as a diagnostic measure, and that created huge amounts of false positives within the female population. But now the studies that are looking into this show that it's a much lesser dominance than was previously thought, and they think that because of some of the bias that exists medically, there's a tendency to underdiagnose this condition in males. So I think that's something that it's worth being mindful of clinically. The other myth is that it is an unhelpful diagnosis, as I touched on before. Kind of feeling that feeling that it can medicalize or create illness behavior. However, it's been shown that with really quite a large body of research now, that and a lot of it based on patient feedback and outcome post management, is that diagnosis of fibromyalgia enables sort of proper management of the patients. It helps them explain their symptoms. It stops it's kind of diagnostic seeking, so it stops them looking for answers and causes and sort of ongoing investigations, and it can provide the key that's needed for them to begin to live well again, and to begin to make more positive changes. And it's also been shown that it can reduce the kind of siloing of conditions. So, sort of it stops somebody getting treatment for a shoulder, treatment for a knee, treatment for, all the separate things in separate medical entities. And it can bring management much more together in the home. So fibromyalgia is a condition characterized by persistent widespread pain that's associated with intrusive fatigue, sleep disturbance, impaired cognitive and physical function, and psychological distress. And it's one of the subgroups of chronic primary pain. So the Royal College of Physicians recently released new guidelines to support the diagnosis of fibromyalgia in March this year. And they're really very nice guidelines that are really kind of clinically supportive. And they've got lots of lovely graphics like this one that are helping to try and address one of the main problems with fibromyalgia, which is the complexity of diagnosis. So it's clarifying kind of how to handle the complexity of the symptoms, and it's drawing attention to some of the alert factors and how to kind of change your clinical assessment along that line. So this diagram here shows some of the alert factors, because often one of the challenges is that often patients don't bring together all their symptoms themselves. So, often they come and present to us with one of the things that's their dominant concern at the time, like kind of low back pain or shoulder pain, or kind of some specific area, or it could be fatigue or mental fogginess, and often they're not bringing them together themselves. So it's just about kind of clinically having the awareness of kind of asking questions round about these symptoms when you see anybody with chronic pain. Uh, so it is, yeah, bringing together the whole person, so the bio, the psycho, the social assessment, and it's difficult to do because you need good time, good rapport, good kind of clinical relationship with the patient. And it's good to have an awareness of the type of pain that presents, which is categorized as nociplastic pain. So that's pain caused by a disturbance in peripheral and central nervous system pain processing. There are lots of differential diagnoses for this, including kind of MS, FND, and there's huge overlap with chronic fatigue, ME, and Ehlers-Danlos syndrome. There is a requirement to do a wide gambit of investigations, kind of the full blood workup, to exclude any other conditions. Sorry, I'm coughing. But I don't think I need to teach you guys all that. So this is a diagnostic worksheet that brings together the kind of symptom severity index, which is your things like fatigue, mental fogginess, abdominal pain, depression, headaches. And it also highlights the number of areas in their body in which they're experiencing chronic persistent pain. And this is very much an adjunct to the rest of your worksheet. It's never supposed, your workup, it's not to be used in isolation. It's definitely not supposed to be patient self-report. So this is an add-on to the usual kind of whole person workup that you do. But it does give you a score, which is helpful on the kind of, the severity really, that then triggers a fibromyalgia diagnosis. And the RCP guidelines say that there are quite a lot of people that sit on the threshold, and they think that there's a value in safety netting and in that you draw awareness to patients that are on that kind of diagnostic sort of edge. There is definitely not a symptom progression. So there's nothing that will say that they will absolutely end up having a diagnosis of fibromyalgia. That's not how this develops. But they think there's a value in discussing around the condition, safety netting, drawing attention, again, just to aid better management of the person. And often people that present, they are coming up and down, and their symptoms can have periods where they might, be diagnosed with fibromyalgia, and then other times where they would be under that threshold. So it's just a way to kind of manage the whole person and the changeable nature of the presentation. So as in regard to management, there are a number of guidelines, and the most recent ones are the European the EULAR guidelines in 2006, they have a lot of commonality between the kind of the management guidance that's given to it, with a strong non-pharmacological focus from all of them. Patient education is always the kind of key in order to help them understand their pain, reduce the fear and anxiety surrounding the condition. Multidisciplinary management is always advocated, and activity or exercise kind of used therapeutically is always the mainstay of treatment. Psychological interventions are also always encouraged, with CBT being the one that's most widely recommended, but that's only because CBT is the thing with the most evidence for it and the most amount of research to it. And definitely within our team, it's not something that they use in isolation. There's also recognition among, like, sort of within the guidelines that patients with more complex and severe presentation need a kind of even more in-depth biopsychosocial assessment and more specific management. So in regards to the EULAR guidelines, you've got your kind of history examination where the diagnosis is triggered, and other kind of what do we call them, amplifying conditions are managed, and then they're given education and information on their condition at the earliest opportunity, so that that initial diagnostic phase information and support should be shared. If they're unable to self-manage with sort of simple advice and information, then there's a recommendation that they have kind of individualized sort of physiotherapy and support. If that is insufficient to manage them, then that's when there will be a stronger psychological component that needs specific one-to-one management, or the severity of their pain or sleep disturbance requires a pharmacological intervention. And if their condition is hugely affecting their life and work and, you know, kind of function, then that's when they need the kind of MDT support. So this is very much the kind of bracket that we're involved in. But you can see from that the kind of pharmacological management of fibromyalgia is really reserved for that small, you know, kind of smaller population of people. And the research shows that even within this bracket, if you know, the pharmacological management, like your duloxetines and things, still have a very small gain. They're only showing about a 10% gain for the patient, but in patients with that sort of that complexity, 10% can be quite important. So, but it's just to bear in mind that that's not a gain that would be beneficial for somebody with less life impacting presentation. Hello, Steve.
Yeah, what would you say about pregabalin for fibromyalgia? Have you found that's been successful for people?
Have I?
Hmm.
I think they all tend to be on duloxetine now, don't they?
Hmm.
But yeah, well, the research is definitely like duloxetine and pregabalin seem to be kind of even Stevens, really. But as you know, prescription isn't something that I should be talking about. But you're
Okay.
I think there are better experts in the room than me. But no, I think yeah. Um,
Uh-huh.
I've certainly seen patients on a combination of all of them. But like I
Mhm.
say, I think I see the more severe end, don't I? Yeah, so that they're the EULAR guidelines, and so this is the
Uh-huh.
ones that we treat in the clinic.
Yeah, I was going to say that, everybody I see is saying if they're taking things, it's only taking the edge off.
Yeah,
So they've still got high pain scores, and they've got a lot of sleep problems and a lot of disability when they're taking the medication as well.
yeah, yeah, and the EULAR guidelines as well recommended that even in that more complex patient group, the medications to have a sort of 6 month, and then they should have a weaning trial and, you
Yeah.
know, a reevaluation. So and I think that's the thing with fibromyalgia, isn't it? It's not a forever diagnosis, and it's something that needs to be continually revised, reassessed, because it is something that people can come out of. So
Mhm.
this is a very
Oh,
simplistic diagram
sorry,
that
Neil
was a
wanted to come
yeah.
in there as well.
Oh, sorry. Yeah, playing with my hand going up and down there. But yeah, it's funny. Always listening when the topic of pregabalin comes up, because it's one of those bête noire, really. just trying to avoid kind of in the community, but some people have found, and by this I mean clinicians, I think have, and probably we did in early years, a few years ago, thought that this was going to be, you know, a savior sort of drug, but it isn't. And unfortunately, it does have, there's a big community kind of knock-on effect, as I'm sure, you know, people will be aware. It's implicated in, I think is it a third of drug-related deaths, pregabalin and or gabapentin, but certainly pregabalin's up there. It's definitely one that's sought out in the community as an opioid adjunct. But notwithstanding the sort of community effects, even on a personal level for individual patients, it doesn't seem to be that great. And it seems to have quite a few negative effects as well.
There's so many of the side effects that cross over with the symptoms of fibromyalgia as well, with the difficulty thinking and the brain fog and fatigue and all these things. Yeah. But certainly, yeah, it was initially pregabalin was really popular in prisons, yeah, for opiate users, it doubles your hit that you get from the wee packet. Yes, which it's a bit of a problem. Sorry.
The other interesting thing, which I didn't want to digress too far, you know, as we go through the presentation, I'm making lots of notes on interesting points in there, but I think it's going to take us into this idea of when we even set out on this journey with the patient. Ideally, we've individually internalized some of these ideals and lessons, and we can actually kind of explain them and try to give people an idea of the potential landscape. Because you've got to remember, when people come in through that door, people come into me and later on to you, and they're like, well, I've got this, my friends had this, or I've had this diagnosis for so many years given to me by somebody else, and I'm expecting a fix or another tablet to make it go away. And of late, I've been, you know, trying to move towards things like the exercise, stretching, progression, all that sort of thing. I know we've talked about it before, and we will talk about it again. It's a hard sell.
Yeah.
You know?
Yeah. It's, but I think people are like,
not easy concepts for I know we're talking biopsychosocial, but they're actually for non-medics to get a grip of. You know, your general population, they don't. Yeah.
No, but it is changing, and I think all we can ever be really is honest. And so I think I'm often quite honest, sort of perhaps brutal in saying things like, you know, kind of best case, the research shows that you're going to get 10% benefit from that medication, you know, and if you're telling me you're getting this, or, you know, whereas the other research shows that, you know, kind of if we do this will give you a kind of greater gain because that's going to be the change, you know. So you can, I think it's about expectations, isn't it? You know, we can try it, but that's what that's what you can expect from it. But I know it's a hard sell. It's definitely a hard sell. But
and also the provision of information. I know we're going to I guess we come back to information sheets, websites, and that sort of thing. And again, I'm starting to use the Pain Info website a bit more. And you know, I guess we as a group and others learning from this series will need to be thinking about, well, what are we going to have to handle that we can hold of?
Yeah, I've got a sheet. I've got a list of things at the end.
Brilliant. Okay.
And some of them are quite helpful. And I'll try as well and be kind of, I'll try and be obvious about which ones I think aren't able to do that, you know. And I think recognition of the fact that some people aren't able to do self-management is very important, you know, because I don't expect anybody that comes to see me to self-manage, because that's why they're there, you know. So I think we have to be realistic. So this is a kind of, I don't know why I did it as a line because it's not linear, but these are the various things that are involved in supporting somebody with fibromyalgia. So you know, it's the kind of The one with the head is about making sense of pain. So sort of trying to take the fear away from the diagnosis, helping them understand what pain is, and specifically what fibromyalgia is, making sense of what they feel, what they think, and how their energy is. Acceptance is a bit of a word, but I'll come on to explain why. And working towards their goals of, what do they want to get out of life? What does their life look like? The gradual exposures, that's about activity. And I'll go back a bit, sorry. And getting them towards where they want to go, and then a whole gambit of things that I've put under lifestyle changes that help support the kind of whole person. So making sense of pain. So what I mean by that is that often by the time people have a fibromyalgia diagnosis, or certainly by the time they come and see me, they've often had a long and sort of fairly arduous journey, to be honest. And they've collected a lot of kind of specialist, non-specialist advice, opinion, and all kinds of things, and been told various things that all impact their beliefs and their thoughts about their pain. And it can be an awful lot to unpick, but it can be really valuable in doing so, because we have the power to sort of reframe a lot of their beliefs to help take the fear out of things like scans, description of their condition, and help kind of understand their anger and frustration. And I think that if you understand kind of what they think about pain, and understand their fears of what's going to happen to themselves, like thoughts about ending up in a wheelchair, or never going to be able to work, or can't look after their family. It explains an awful lot about some of the choices that they're making, such as kind of avoiding movement because they feel that they're doing harm, because they believe themselves to be fragile. And it can be very valuable to start repairing that at that very initial consultation. So the RCP in their guidelines, and other studies recommend that good practice in regard to making sense of pain is to validate their pain, make them feel kind of believed and understood, give a very personal explanation of why they're sore. So explain kind of pain as part of protection, make sense of why they're behaving like they are, make sense of the fact that they've changed their physical function in a way that we're designed to behave in response to pain, but that's no longer helping them. Challenging some of their beliefs, but in a nice way. So, kind of helping them understand that wear and tear isn't fragile, that their things aren't torn, they're worn, and it's a balance between kind of normal process in their body. Addressing fears. We don't have a magic ball, we don't know what the future is, but there are an awful lot of people that think that they're going to be in a wheelchair, and there really is no justification for those kind of beliefs, and you can reassure that that's not the expected course of their condition. Fibromyalgia certainly has not got a timeline of progression. People can recover from it. They can also get worse within the condition, but there is the capability of recovering, and it's not a gradual disease process. So those kind of fears can be allayed. An important thing to do is to really share lots of resources and support with people that have the capacity to take that on. Our language is hugely powerful, and it's been shown to be massively pain amplifying and also pain depressing. If you give people the power to understand that their body is safe, pain does not indicate harm, our bodies are robust, they're capable of recovery, our bodies are amazingly plastic and have the ability to change. People have the ability to live without pain, or certainly with less life-affecting pain. And changing them away from the kind of can't, shouldn't beliefs into the kind of I can, I should, and I'm capable. Obviously, don't do that in one setting, but kind of everything we say has power. So we use things like the pain cycle a lot, especially within fibromyalgia. It helps people understand why their pain is worsening and their physical function is reducing without any underlying change in their kind of pathophysiology. So we do it by explaining that pain makes you guard, it makes you naturally protective. That's an understandable lived experience with pain. You know, when we cut ourselves with a knife, we don't do it again. We're more cautious, we're hesitant, we look at what we're doing and we're very careful. If we experience pain, our body responds in the same way. We're careful, we're protective, we're guarded. But as a result of that, we get less fit, we are less confident moving into range. Over time, we create no-go areas and we create things that we avoid. That leads to sleep, deconditioning, loss of kind of independence. Your world shrinks a little bit. It impacts on your mood, on your sense of self. The next time you go and do a task, you're less robust, you're less strong, you're less capable, and you will experience pain more readily. In a sort of very simple, super quick thing, that's basically the pain cycle. Most people with fibromyalgia recognize themselves within it, and it can help make sense of why they're feeling worse. An important thing to go on from this is the fact that that cycle can change. So by increasing your body's tolerance of things, by doing things within your capacity, slowly nudging up your tolerance, regaining a little bit of physical confidence over time, regaining jobs around the home, self-worth, introducing fun back into your life, you begin to move out of the pain cycle where pain is not the dominant thing and you're moving back towards things of value in your life. Acceptance is a big thing, especially when you give somebody a diagnosis of fibromyalgia. And acceptance isn't necessarily a word we use with the patients. And it definitely doesn't mean kind of giving up or accepting that this is what you've got and this is what you're living with. Acceptance is about living with change. So fibromyalgia and any widespread pain diagnosis has a huge, massive impact on somebody's life. It will change their identity, their role, their job, their friends, what they're doing with themselves. And it's got an associated emotional response of kind of anger, denial, depression, frustration, and eventually moving into acceptance. Acceptance means that you're able to recognize that this is what you are. You're somebody that has persistent pain as part of you now, and that it's okay to make the changes that you need to make to move on with it. It's part of stopping giving yourself a hard time and allowing you to move on. But acceptance is a huge Marmite word, but it's definitely something that our psychologists do with patients a lot, and we support them kind of through that journey so that they can begin to make changes, get rid of some of the anger that's holding them back. And stop looking for the kind of curative expectation of things radically changing or things. Acceptance is often, I think, best summarized when people are waiting for a point in which their pain isn't there and then they will do whatever it is. You know, then I will start to exercise, or then I will work again, or then I can look after my family. There is never going to be a point where the pain isn't going to be in the room. So it's about learning to start to live again with pain with you as part of you. But by moving forward and starting to live life, the pain isn't the dominant thing anymore. You're focusing on your values, on things of importance. And although the pain's there, it kind of goes back a little bit. Graded exposure is kind of what we do as physios within people, and it's not necessarily about exercise and doing more. It's about giving people new experience. So a lot of pain is perceived. Pain is a perception rather than a sensory input, and so what we're doing is getting people to move and experiencing it in a less threatening way. So breaking down activities of value, getting rid of guarding, and getting them to move more normally in the space with less apprehension, and slowly nudging tolerance over time. And activity doesn't need to be exercise or specific kinds of exercise. There's no perfect, safe, kind of recommended rule type of exercise for fibromyalgia. People don't all need to do kind of Pilates and yoga and like hydrotherapy. They can do whatever exercise or activity is important to them. The most valuable, most evidence-based activity is something that the person wants to do. So that can be doing all the kind of cleaning in their house, it can be going cycling or mountain climbing, but it has to be something that they're invested in. And we just work with them to do it within their tolerance over time, and try and give them new experiences of learning that activity is kind of fun and safe and not harmful. And then lifestyle changes is just lots of stuff. So trying to get, realizing the value of telling people around about them how they're feeling, because pain is a hidden thing, and sharing how you're feeling with friends, helping them understand your tolerance is very important. opening your world again, so beginning to get fun back in your life. A lot of people that certainly see us only ever come to hospital appointments, or rarely leave their house for fun, and so it's about re-injecting kind of things of kind of fun in their life again, and breaking down some of the barriers that are preventing that. Obviously, the whole person's always important in this. We know the impact of smoking on pain and diet on pain and all kinds of things. So doing that whole person approach is important. Sleep is massively important in pain, as we all know, and especially in fibromyalgia, where they don't get the normal recovery from rest. We try and look at strategies to just decompress the system, get it out of that hypervigilant state so that they can rest a bit more effectively. So I thought I'd finish by the draft framework for chronic pain delivery in Scotland is they've got these 4 aims: so person-centred care, access to care, and then the other ones are about kind of improving the provision of care, really. But I've kind of starred 2 things that everybody that's in contact with patients can do as a first line, and it's that improving the quality of information we give people on that very first consult, and improving the rapidity with which people are diagnosed and therefore effectively managed with fibromyalgia, and just increasing our communication so that we give people nice resources at the right time. So there are lots of resources on fibromyalgia. As always, some are better than others. The Versus Arthritis people actually have really quite nice information on it that I've linked here, as do the RCP. They've got a very simple sheet that goes with their diagnostic workup that you give to patients. Very simply defines what fibromyalgia is. And is kind of a good start that you then can enhance with other sort of deeper resources if somebody's able to self-manage. The University of Michigan has a huge website with lots of links for somebody that's really very motivated, and would be able to do things like use the sleep programs that they have, use the graded exposure programs that they have. There's an awful lot of resources in the Michigan website. And the Fibromyalgia Action UK information booklet is actually very deep. It has a lot of information on it, and it covers a lot of topics that would provide quite a lot of support for somebody if they wanted to access that. This is just general pain management resources, which definitely are important for managing fibromyalgia well. The Flippin' Pain website has lots of stuff, and they've got a nice podcast series. The Pain Association Scotland have a lot of webinars as well on their website. They're quite valuable. And the Sleepio online NHS programme is available to everybody online as well, which is quite a nice programme for anybody struggling with sleep affected by pain. These are resources for clinicians to do with fibromyalgia. They're quite handy. And then after that, I've just put all my references on. So that's it. So I will.
Thanks so much, Claire. That's
okay.
fantastic. Yeah. You're surviving with your cold. I hope you get to take some time off work.
I don't have a cold. No, I think it's just I don't know what it is. I've just got a tickly throat. I'm trying to stop sharing this thing. It's always the same.
Yeah, I think the changing diagnostic criteria from 2011 to 2016 has kind of expanded the number of people you could diagnose with fibromyalgia, really, and taken out the tender points, and included quite a lot of more of that psychological distress, the brain fog and difficulty concentrating and things like that.
And I think bringing in the kind of abdominal pain, the kind of fogginess, the fact, do you have recurrent headaches, and bringing over all those kind of pain presentations has made it much handier than the sort of tender points, which was always a bit of a false positive, wasn't it?
Yeah, I think there's massive crossover with irritable bowel syndrome and pelvic pain, and all the other that you were saying with people who have a possible diagnosis of early Ehlers loss or hypermobility, and then they get the postural orthostatic hypertension and tachycardia syndrome, and people can become really. Sometimes I think they can be quite. I think this is a biological thing, and there's nothing that can be done about it. Having said that, I mean, there's some biological findings which are really quite striking recently about fibromyalgia.
Yeah.
There's a reduced number of pain fibers or C fibers in the periphery, which is really quite a strange thing to find.
Yeah.
You would think.
And there's all the change in all the kind of neurotransmitters and all the change in like the substance P stuff and everything, and like even all the central changes as well. Huge differences in kind of lots of brain tissue and big peripheral sort of like big peripheral nervous system and central nervous system change. And all the stuff with the
One of the things I wondered though
Steve.
is, is that chicken and egg.
Is it?
So you've got a pain experience, and so then you've got lots more neurotransmitters, and you do your functional MRI scans, and you see more areas of increased perfusion in the brain because there's more neural activity there. So I think it'd be really interesting to look at people doing pain management techniques, exposure, and information, and the acceptance-based approaches, and see whether that changes the biological things that we're trying to measure. Sorry, Neil.
You actually said just what I was thinking, given the currently recognized plasticity, which is a cause or effect. But you're right.
So it's like if you learn to play the piano, then you increase the amount of brain activity in lots of brain areas, in your hand and your auditory cortex and your imagination and so on.
I think that's why the whole kind of neurotagging thing all fell apart, wasn't it? It's just it's very difficult to show kind of cause.
There's very persuasive neuroscience researchers though that are doing these beautiful functional MRI scans. One of the first international pain meetings I went to was there was Patrick Wall there talking about the beautiful pictures he'd seen from the functional MRI phrenologists, and he had a wicked sense of humour, Patrick Wall, of Melzack and Wall fame. And he said, we were looking at this with positron emission tomography scans 20 years ago. We saw all these areas lighting up, but we weren't looking at pain. They were looking at people that were thirsty, and so they saw exactly the same so-called pain matrix active in people who were suffering another kind of suffering apart from pain.
I think that is what makes it difficult, though. The landscape and the things are changing quite rapidly in understanding, and the whole kind of like immune system thing, there's
lots of cytokines and the interleukins are all involved as well.
And that study where they injected rats and made them fibromyalgic, didn't they?
Yeah.
So it's kind of there's some really interesting stuff, and I think basically we still don't really know, but we know that all of them are a little bit involved, but we don't know. All we know is that it is complex. I think that's what you can say with certainty to your patients. It's complex and lots of factors are involved.
I think in the immune cells within the nervous system, the microglia are, particularly involved in this sort of chronic widespread pain. So they seem to increase connectivity and drop thresholds. And they're particularly involved in CRPS probably as well. And we don't really know, how to influence that at the moment, I don't think.
Yeah. No.
Hi, Kathana and Andrew. Thanks very much for coming as well. How are you doing down in Tarbert?
Can you hear?
Yes. Oh,
I think you've muted yourself, I think.
You've gone back off again.
Can you hear me?
Yeah.
Still got that ongoing complaint. which is this is a complaint about a patient that I didn't give diazepam to, who's got chronic pain, and it's going further and further and further and further and further. So the one thing I was going to ask you just very briefly, because I was listening to Claire and that was really, really interesting. See, if we do get complaints from patients, what the MDDUS were asking for evidence, because I had suggested things like taming the beast, all that kind of stuff, flipping pain, chronic pain things. Can I justify? I can use that as evidence that it's evidence-based stuff and all these kind of things.
Yeah. Give them the EULAR guidelines, because they say that that information should be absolutely your first line. And
the EULAR guidelines.
EULAR guidelines, yeah.
It's European League Against Rheumatism, isn't it?
Yeah. And it really is very, very clear that the pharmacology should not be your first line, and that kind of by the time you get into that stage, it is the kind of more MDT pharmacology decision, and even then it's only very temporary and it's reviewed. It shouldn't be part of the mainstay of treatment. So
it's actually getting to the stage now, not that I would, but I was wishing I had just given them the flipping it would have been a lot easier than all this hours of having to deal with this now. But we were trying to find, because the MDDU were looking for guidelines, and I had said to them about taming the beast, and me and Craney were trying to find in the chronic pain guidelines today, and it does talk about other things, but why did you use taming the beast? And I'm thinking, because we've been doing this chronic pain stuff, and it's really useful, and I was just trying to find if there was something I could just say why we used it.
I think some people might be more, especially engineers, I find, are wanting, like that sort of mechanistic approach rather than, and I think that taming the beast is a wee bit out there for a lot of people. Sort of a bit of a fairy tale approach to it, which some people can take as being demeaning or sort of making light of the problem. So there are really good guidelines from EULAR, from the Faculty of Pain Medicine. I think even the Fibromyalgia Association would say that drugs aren't a significant part of the management, and there's loads of evidence for the negative effects of opioids and benzos in pain management over the years.
I certainly didn't come across anything saying that you should do diazepam for fibromyalgia. So here.
What are you thinking there, Chris? You got some useful.
Yeah, we wouldn't, from a pharmacy perspective, we wouldn't expect to see a patient on benzodiazepines for really any type of pain, unless it was acute pain and they had muscle spasm, something like that. So yeah, from a pharmacy perspective, that would be really odd.
I think for a lot of people,
I think the problem was she's come from other GPs who had given her 56 diazepam at a time, and she wanted to know how I felt I was more qualified to say no, and did I think I knew better than all these GPs before her, but before that I prescribed it. And it's really, really difficult then to actually, and then she complained that I didn't give a patient-centered approach, that I was useless. It was 19 pages long. And that I didn't give her patient-centered, I didn't give her time, that she told me she was suicidal and that I didn't do anything about it, that she hadn't asked for diazepam, but if I felt the diazepam was too high, why did I not offer her? And that I had spent an hour and a half with her, and I had, but I hadn't given her enough time. So it's really difficult, but it just takes up so much of your time to try and then justify what you're doing, and you're doing it for their own best interests.
I think you've really got to be really careful with that writing reflex. That if you come across somebody with some ideas that you think are a bit off the wall, then you have to sort of work at that gently, rather than directly contradicting, and watching out for people that have been to doctors before, where you might not agree with what they've done, but you have to put that very diplomatically and say that things have recently discovered that in fact that the things we used to think weren't as useful as we thought, and but it sounds like you get somebody coming in like that, and if they're going to have a big bust up with you, then you maybe just have to say it's not something I can help with. You have to find somebody else to see. What would you think, everybody else? Do you fire many patients, Andrew?
Andrew.
It's now impossible. There's no sense getting into arguments because it never ends well, but equally you can't keep perpetuating what is ineffective management of chronic pain, and ultimately you do have to try and move things in a direction that is likely to help the patient. I was going to come in with another point. I just out of interest Googled fibromyalgia. The first link that comes out is the NHS UK condition guide to fibromyalgia. It is appalling. And then that's the stuff that people will be getting. And even if you just scroll to their treatment section, the opening line, well, there's medication. You may need to take several different types of medicines for fibromyalgia, including painkillers and antidepressants.
Yeah.
Mm-hmm.
And then it lists painkillers, antidepressants, medication to help you sleep, muscle relaxants, anticonvulsants, antipsychotics, other treatment options. It's just awful.
Yeah.
And then there's a little section on alternative therapies.
Oh dear.
And then there's a little section on treating other conditions.
Yeah.
And when that's like the top Google link that comes up.
So that's on NHS Inform?
No, that's English. It's the English NHS UK site.
Yeah. Yeah.
So
NHS Inform is a lot better.
Yeah.
They've been working with the MSK team for quite a long time, and it's a lot better, because I was a bit involved in that, and it's definitely better than, but it is terrible because you do type in NHS and you don't get the good one, you get the rubbish one. Oh, how is this still here? It's embarrassing. And I think that is a huge problem, isn't it? Because you have stuff from reputable sites that's just the worst kind of management, and it definitely doesn't help that horrible rubbishy management of this. It's just not nice.
Mm-hmm. No. Yeah, I think a lot of the problems with patients are, having tried many things and they've all failed. It's a really discouraging experience where they try one thing and try another, and then they get into a combination, and all of it is just not really making much difference.
Yeah.
Mm-hmm.
Yeah.
So, sorry.
But on the positive, when you do manage it well, it can be very, very good. People can do very well with a fibromyalgia diagnosis and live very well, and it's not,
I think that's a thing that can be really positive to show people is the Flippin' Pain website has patient stories, and so I think that often patients can come to us and we say, oh yeah, the drugs aren't any good, and you should need to do more exercise and live more healthily and relax and sleep better, and they all say, oh yeah, he just doesn't want to give me any drugs. So having real person feedback from people that have been in the same situation as them, I think is really, really important. I think as well the experience of people that have been on a lot of medication and managed to come off, and their pain's not any different, and they actually feel better in themselves. I was thinking about doing a future episode about reducing drugs. I think that's an idea. Yeah, you've had really good success with that in Tarbert, haven't you, Cathana?
Yeah, we've got this wee chronic pain clinic that's gone. Steve came down to have a wee look at it a couple of weeks ago there, and we're slowly building on it. But a couple of our patients have come down from fentanyl patches, and there's one guy just on cocodamol 8500. So just with that little bit of spending time, we do it once a month on a Thursday afternoon and give them a couple of hours of our time and just let them talk to each other. And we keep on trying to encourage them to do it themselves, but they really do like this. They do like coming at the surgery and being able to ask questions. But no, and we've had different different people in talking, the psychiatrists, the physios, and different things. So it's been really, really good.
So, Cathana, is that a group
it's a group
process? Because 2 hours per person is a lot.
It's a group of patients, and it can vary from anything from maybe 3, at the most we had 15. So it's been really, really useful in that you do have the time then to spend with a group of patients, and then they encourage each other because they've now got a Facebook page. And actually in October, they're trying to set up a thing where in the local village, all the people that could be involved in pain, like massage therapists, any kind of psychology kind of type things, are all going to get together and try and advertise what's available locally to help with pain.
There's one of the patients that's come down from Loch Gilphead is looking to set it up there, isn't she?
Yes, because she's found
I don't think she's replied to me on the email, but I think it's a really when I went down to Campbelltown and Tarbert last year, I sort of followed up by phone how the visit had gone a month after I'd been there, and in Campbelltown, when I went down this year, they're still thinking about it. Tarbert were right off the starting blocks and got their group organised a couple of weeks after I'd been there. So it's fantastic. It's really, I think, a very useful model that's helping a lot. Being in the health centre, I think, is when you've I think if you combine that with voluntary organisations, it gives you much more validity for patients. But I'm conscious of the time. We've gone on till 8 o'clock. I'm not sure that 7 till 8 o'clock is a popular time for the chronic pain learning series, but but I'm really glad that you were able to give us your talk today, Claire. That was really, really good. And I think if you have a look on the Highland Pain Info website, then I'll post the talk on there, and there's the Royal College of Physicians guidelines on fibromyalgia, as well as the pop on the EULAR guidelines too. But we might all get off to get back to our normal lives, I think, if you're all happy. Yeah. But thanks so much for everybody for coming again. And we'll try and I'm off to the International Association for the Study of Pain World Congress in Toronto in a couple of weeks. So that'll be really exciting. And I'll try and organise another session for the end of October once I'm back and see whether I found out anything or not.
Bye, nice to meet you.
Yeah, thank you very much. That was great.
Okay, cheers. Thanks again. Bye-bye.